Good afternoon, and welcome to a first look at North Carolina Online Brain Injury Screening and Support System OBISSS platform webinar. Before we get started, here are a few reminders about the webinar technology. Please make sure you're using a computer or smartphone connected to the internet, and the audio function is on and the volume is turned up. Please be sure your microphone is muted for the duration of the call. Questions can be submitted anytime during the presentation using the Q&A feature located on your control panel. American Sign Language interpreters and closed captioning options are available for today's event. The American Sign Language interpreters for today are Susan King Lanier and Talisha Edward. For closed captioning options, select the closed caption feature located on your dashboard. To adjust your video layout in screen view, select the view feature located in the top right-hand corner of your screen and choose the view that works best for you. Today's agenda topics include introductions and overview of brain injury, a review of the online brain injury support system, OBISSS, and a question and answer session. At this time, I would like to turn it over to Scott Picorni, Traumatic Brain Injury Lead, IDD, TBI, and onset section for the Division of Mental Health, Developmental Disabilities, and Substance Use Services.
Good afternoon, everybody, and thank you so much for joining us today to learn more about OBIS. I also want to extend our thank you to the Disability Rights North Carolina team for bringing OBIS to North Carolina last year, and we have been in collaborations with them to transition the platform over to the state and look forward and appreciate our continued partnership with them. We are super excited to be rolling this out statewide. It is the first time that we will have a statewide online platform for brain injury screening. Also wanted to just highlight that the OBIS is a part of our TBI State Action Plan strategy, and that action plan was kicked off on July 1st of this year, 2026, and OBIS went live on August the 1st, and that is one of our state action plan goals. So at this time, I would like to introduce Amanda Neeser. She is the program manager and OBIS administrator with the National Association of State Head Injury Administrators. And Amanda, I'll hand it off to you.
Thanks, Scott. Good afternoon, everybody. I am with NASHA, the National Association of State Head Injury Administrators. My colleague Haley will tell you a little bit more about us in a little while, but very quickly, we are an organization that helps those who help those with brain injury through a variety of ways. And we also are the organization that developed the OBIS. I am a program manager and the OBIS administrator at NASHA. And Haley will lead our training today, but just as a quick introduction to me, in case we ever connect again, my role in the system is kind of more in the programming, development, technical side, reporting, and kind of general customer service and maintenance. So at this time, I'm going to turn it over to Haley to take you through the rest of the OBIS content.
Great. Thank you, Amanda. Hi, everyone. As Amanda said, I'm Haley Cushion with NASHA. I'm the Director of Program Management, and one of the programs that I get to direct is the OBIS program, which we're here to talk about today. If you have any questions for us, just please put them in the Q&A and we'll get to them as we can. Next slide, please. We're going to start with an overview of brain injury and how we're going to frame it today in context of brain injury screening. Some of you may already know about brain injury, but I invite you to listen to the content and follow along. Next slide. So when we're talking about brain injury in the context of the OBIS and screening, we're talking about acquired brain injury, and this is brain injury that occurs after birth. We're looking at two different types of acquired brain injury. The first being traumatic brain injury, which is a brain injury that occurs due to external force or impact. Think about external force impact being gunshot wound, assault, falls, sports concussions, blast injuries in combat, and motor vehicle accidents. The other type of acquired brain injury we're going to be talking about is non-traumatic brain injury. And I want to note that non-traumatic brain injuries do happen in a very traumatic way for the individual, but they're called non-traumatic brain injuries in the brain injury community. And these are internal events, internal events, such as stroke, tumor, lack of oxygen, infection, lack of oxygen due to near drowning, strangulation, and also drug overdose with reversal. Next slide. I want to talk a little bit about concussion because concussion is very much a part of news cycles and what we hear about and think about when we think about brain injury. So when we think about concussions, those are more on the milder end of the spectrum of brain injury. Even though they are on the milder end of the spectrum, they can have significant impacts to an individual, and especially they can have long-term impairments. When we think about concussion, a lot of people think of, oh, you've had a brain injury if you've lost consciousness. But 90% of concussions are not associated with loss of consciousness. They may show other symptoms immediately or later on, but they don't always have a loss of consciousness. So when we talk about brain injury in the context of brain injury screening, we may be talking about identifying concussions that were undiagnosed, or even the individual was unclear that it was even a concussion or a brain injury because they themselves were looking for a loss of consciousness. Many mild brain injuries, up to 90%, do go unreported, and that's because several reasons. It may be that the person that experienced the mild traumatic brain injury doesn't recognize it as a brain injury, as I just mentioned, because they may be looking for that loss of consciousness. They may be told by a coach or a parent, you're fine, rub some dirt on it. They also may not have insurance, not have a medical provider. They may fear repercussion of reporting the brain injury or going to getting medical support due to how they acquired the injury or their citizenship status, or they may fear that they may have legal ramifications because of the how they sustained their brain injury. When often I get this question about, well, if I've had a brain injury, I must need a CT scan or an MRI. When someone goes to the ER or the doctor following a suspected brain injury, the CT scan or the MRI is looking for brain bleeds, brain swelling, or any anatomical changes. They're looking for something more than a concussion. A concussion happens on a cellular level and can't be picked up by a CT or MRI. So if someone screens positive, for instance, for a potential brain injury with the screener that we're going to be talking about today, they may ask, oh, do I need to go get a CT scan? That's not necessarily the case unless they're experiencing symptoms that may lead to them needing further investigation of their brain injury because maybe it's recent or they're experiencing severe symptoms that may need to be explored by a medical professional. 2 reasons why a milder brain injury may result in lasting impact or impairment is repeated exposure, meaning that someone has received multiple of those milder brain injuries or concussions, and that could be because of repeated abuse, sports-related concussion, or combat. Another reason that a milder brain injury may have lasting impact is because there could be a co-occurring condition such as substance abuse disorders or a mental health condition. A brain injury with a co-occurring condition can show lasting impact and impairment. Next slide. So this slide right here shows us that there's several vulnerable populations or subpopulations that experience brain injury at a much higher level and higher intensity. So how we're going to read this slide is that the general population of those that sustained a brain injury, 22% of those brain injuries had a loss of consciousness. So that shows that 78% experienced a brain injury with no loss of consciousness. That main indicator that a lot of people think about when they think about brain injury. It also tells us that of the general population that experienced a brain injury, 5% of those were classified as moderate to severe. When someone receives a brain injury that's more moderate to severe, they typically know they've experienced a brain injury and may not even need a screener to tell you so. In the criminal legal system, compared to the general population, 50% of those that experience a brain injury experienced a loss of consciousness, and 14% of those experienced a mild to severe brain injury. So 14% experienced a mild to severe brain injury in the criminal legal system population versus 5% in the general population. So that's almost 3 times as much. That's a big difference. Next slide. When we talk about other special populations or vulnerable populations that may have a higher incidence of brain injury, we think about veterans as well. And many of us may think that the reason that the veterans experience more brain injury is due to combat-related injuries, such as blasts or falls. We're actually seeing that 80% of the brain injuries since 9/11 have been non-combat related. And that could be associated with more intense training, so training-related injuries or on-the-job related injuries. And also, it may be associated with the risk-taking behaviors that many of the younger men, especially in the military, experience, and such as wanting to ride ATVs or wanting to participate in more, intense extracurricular sports and things of that nature. They also have a higher risk of assumption of alcohol for military personnel. And so that can also lead to a higher incident level of brain injury. Next slide. Another area that we see a higher incident level of brain injury is those that are experiencing housing insecurity or homelessness. One study that looked at over 2,000 respondents showed that 43% of the respondents reported a history of traumatic brain injury, with the average age of the first injury being 15. So it could be that the impairments of the brain injury led to poor decision making or factors that led to housing insecurity. It also could be that the brain injury was sustained while experiencing housing insecurity, maybe through abuse on the streets or overdose with reversal or falls, things of that nature. So as we're talking about these two slides and these special populations, when you have someone in your caseload that maybe is a veteran or has military experience, or someone who is experiencing housing insecurity, that could be a flag for you that a brain injury screening may be beneficial to that case and to that individual. Next slide. Another area that we see high incident level of brain injury is those that experience an intimate partner violence or domestic violence. One study shows that as many as 23 million women in the US have experienced intimate partner violence. They also live with a brain injury. Many of those brain injuries occur with a blow to the head, strangulation, being hit against something. And many of the individuals that experience the blow to the head, strangulation, loss of oxygen, 30 to 74% of them will not be seen in an emergency room. So that's also maybe a flag for you to give a brain injury screener if you know someone has been involved in domestic violence or intimate partner violence. Next slide. Another higher incident level population is those that have experience within the criminal legal system or the criminal justice system. We found through a meta-analysis, a study showed that 8.5% of the general population have a reported history of traumatic brain injury, compared to 60.25% of the justice population reporting a history of traumatic brain injury. So there is a huge incident level of those that experience traumatic brain injury and have history with the criminal legal system. And we're also seeing that with the data coming in with OBIS that is in the 20 states so far as well. Next slide. So we're going to go talk about that OBIS that we've been referring to, the Online Brain Injury Screening and Support System. There are 3 S's. Next slide. So this is an online screener that determines the potential that a brain injury has existed in a person's history. So it's not a diagnostic tool, not telling a person, yes, they do have a brain injury. That takes a medical professional. But what we are seeing is if they have a potential brain injury that may still be causing challenges today. If they do, we're also going to identify any associated challenges that they may still be having. It is useful for youth and adults. It looks at traumatic brain injury as well as non-traumatic brain injury, the ones that we talked about at the beginning of the presentation. We're also looking at those challenges related to any potential brain injury. And we're going to have strategies and tips. The OBIS gives strategies and tips to the individual to help them navigate their world with those existing challenges. The OBIS does then give the provider, you, working with the individual, a set of tips and strategies that are geared towards the provider to help the provider work with individuals that have existing challenges related to brain injury. So we're not just going to say, we think you have a brain injury, have a good day. We're going to also look at challenges that may be experienced and give you and the participant tips and strategies about how to move forward. Next slide. The screener does use 2 established tools within the brain injury community, one being the Ohio State University Traumatic Brain Injury Identification Method, or the OSU TBI ID. It has been around for 18 years, and it's widely used still today. The OBIS also uses the Symptoms Questionnaire for Brain Injury that was developed in Colorado, and we refer to it as the SQBI or the SQBI. Next slide. The OSU TBI ID that I mentioned, that it has been around for 18 years, doesn't pick up on every bump and bruise to the brain. It picks up on those bumps and bruises to the brain that are likely to still be causing challenges. If a brain injury is not likely to be causing challenges to, say, service delivery or interfering with the individual's life, we're not identifying those brain injuries. We're identifying those brain injuries that are causing barriers to a person's service delivery or challenges within their life to be able to function how they want to function. Next slide. The SQUIBI, which I mentioned, the Symptoms Questionnaire for Brain Injury, looks at 9 different areas of challenge. So anywhere from memory, attention, language, organization, emotional dysregulation. These 9 different areas are very common challenges that a person with a brain injury is likely to experience. And we're going to go through a symptomology checklist to see which of those 9 different areas are causing barriers to service delivery. Next slide. The OBIS gathers some really useful data, and this data is going to help inform, let's say, training programs to see where training needs are, where this North Carolina's data is going to show where people are screening positive versus negative for potential brain injury in different settings. And it's going to be really useful to help allocate resources, training, funding, to see where things are needed to support those with brain injuries within your state. Next slide. Like I said, tips and strategies are going to be available to you, the provider, and the participant, and they're going to show you ways to work together to help mitigate the challenges related to brain injury. Next slide. So what is needed to get started? We're talking about the great things about OBIS, but what do you need to know about screening with this brain injury screener that is available to you for free? Thank you to the state for bringing it to you as a provider. It is an internet-based tool, so you need a computer or a mobile device with internet. A paper copy is available if there's not access to internet, but the results from the paper copy do need to be put back into the system in order to generate the results and the tip sheets. You'll need the link or the QR code to the OBIS. You'll need the login information for North Carolina's version of the OBIS, and you'll need a provider email address. The OBIS is made to be self-administered by the participant and professionally guided, but we find that a lot of professionals like to walk someone through the screener, which is completely fine and up to you as a provider. But if the individual is taking the screener on their own, they do need your email address so that the results do come to you, and that they come to someone that can help walk through the tips and strategies. Next slide. There are 3 different levels of administration for the OBIS. That first being participant-led, which I mentioned that the individual can take the OBIS independently. It may be that you see an individual and you feel like they could navigate the screener on their own, and you ask them to take the screener between now and the next time you meet. And then you can discuss the results next time you see them. Some subscribers in some states are encouraging their screening partners or their providers that are screening to put a Chromebook in the waiting room or in a separate room so the individual can take the OBIS before they meet with them, and then during their meeting they can discuss the results. There's many different ways to do it. The next level of screening is provider assisted. This is perhaps when a participant is taking the OBIS on their own in a room or in a group situation, and the provider is around to guide them or ask questions or answer questions along the way. The third level of administration is provider-led. And this is what I alluded to earlier when the provider walks the participant through the screener, question by question. We look to the provider to choose the appropriate level of administration for the participant because you know the participant better than we do. We do ask that the screener is best to be performed within the first 2 to 3 encounters, so the first 2 to 3 meetings with an individual. As we understand, the first appointment or the intake already has a lot going on, and you already have a process of how you walk through your first meetings with individuals. The screener is important to do towards the beginning of service delivery because we don't want the person to be experiencing challenges related to brain injuries such as memory, and they don't have good strategies about how to remember appointments, and you as the provider have to write them off as no-shows or being non-compliant because they don't show up to their appointments. We want those strategies and compensatory strategies to be incorporated early on in the service delivery process so that the participant has less barriers to service delivery and can be more compliant with the services that you are providing. I also like to say here that the OBIS should not be given in a time of crisis. It should not be given in the emergency department or when someone's looking for food or safety or maybe in detox. Those are not the appropriate times for the OBIS as it's not a crisis tool. Next slide. We're going to go into a short video about walking you through the OBIS. Before we get to this video, I do want to say the OBIS is available for youth and youth and adults. It can be given as young as 10. For the youth version, we suggest that someone who can be a historian for the child or the youth is available to answer some of the questions related to the youth's medical history. And then, you know, sometimes some adults need some help with being a historian for themselves as well. But at this time, we're going to show this video, and I'll be back to talk to you more about the OBIS. I'm sorry, the video wasn't there
Once you
yet.
access the OBIS
There we
through
go.
a link or QR code, you will see the welcome page. Please enter the state or subscriber name that you were given and the subscriber code. The OBIS can be self-administered by the participant or administered with the help of a provider. The questions are written as if the participant is answering all the questions, such as which state do you live in? You enter the subscriber code once again and the email address of the professional working with the participant. This is so the professional can get the results of the OBIS. Next, enter the age of the participant. The next screen is a consent form for either adults or youth. Please read this carefully and answer the questions provided. Please note the privacy policy is available through a link. Most versions of the OBIS will then ask for first name and last name of the participant and the email address of the participant. This is if the participant would like to receive results of the OBIS. It is recommended that an email address is provided if they are safe to use email and also have access to email. Next, you will see a completed version of the consent form. This is where you can save, download, or print the consent form at this time. However, it's not necessary as the consent form will also be emailed to the provided email addresses. Next, we will ask questions about the participant, such as gender, race, ethnicity, relationship status, highest grade completed, military experience, and the description of the program that asks you to take the OBIS. Some versions of the OBIS are called demographic light versions and will not show this page. Next, we are going to ask questions about any history of injuries to the brain in one's lifetime. The first several questions are yes or no to questions such as, in your lifetime, have you ever been hospitalized or treated in an emergency room following an injury to your head or neck? Please read the questions carefully and answer the best you can. The next several questions are asking yes or no to have you ever been told by a doctor or other healthcare professional that you've had any of the following: epilepsy, stroke, tumor of the brain, swelling of the brain bleed, brain cancer, brain infection, loss of oxygen to the brain, toxic exposure, dementia, and progressive disease. This is a results screen. It's showing us that the results show that you have had a possible brain injury sometime in your life that may still be causing challenges. Please remember, this is only a screening tool and not to be a diagnostic tool. It is very important that you hit submit on this page, even if you don't have a possible brain injury. Once you hit submit, this tells the system to send the email addresses information about the OBIS. Now we're going to go on to the second part of the OBIS that talks about possible challenges that one may be having as a result of a potential brain injury. This is called the Symptoms Questionnaire for Brain Injury. There's an adult and youth version. There are 9 sections where we want the participant to answer each of the items on a scale of I do not have this problem at all to I'm extremely bothered by this problem. How much in the recent weeks have you been bothered by the following problems? A participant may not have any experience with problems from one of the items, and that's fine. All they have to do is click, I do not have this problem at all. Each section talks about a challenge that's very common to those experiencing brain injury. These items are very important as it provides crucial information to the participant and the provider that can help the participant in service delivery. After section 9, please go to next page. The system will tabulate the score and tell us if the participant is possibly having challenges related to a brain injury and which challenges they may be experiencing according to the symptoms questionnaire. Tip sheets and strategies can be accessed directly from the screen through the hyperlink. And also, once you press submit, the information tabulated by the OBIS and tips and strategies for each of these challenges will be sent to the email addresses provided. It's very important, even if the screen is showing no challenges experienced, that you press submit to end the screener. Once you see the screen, you will know you are done with the OBIS, and you can go to the email address that was provided to see any follow-up information. Thank you.
Great, thank you. Go to the next slide. So, why use the OBIS? Many of you may be thinking it's one more thing that I need to do, have to do. Already have a lot going on. But what we're going to do is we're going to take some time to do the screener, and it's going to save you time on the end and throughout the service delivery with an individual, because you are communicating better. The participant may learn ways to follow along better in a group setting or with instructions that the provider is giving to the individual. We're also eliminating frustrations that you as the provider experience. And I love to also say here that it can help with preventing provider burnout, as many providers experience burnout when they experience repeated frustration with clients, or they don't see any positive results coming from their work. So what we're going to do is use the OBIS to help improve the quality of work, improve numbers, and also improve services. Next slide. So I know this is small print, but I did want to show you what a provider guidebook looked like. On the left is the front view of the provider guidebook, and on the right is a table of contents. You can see that each section is one of those areas of challenge that we referred to earlier. And there's a bonus 10th section, which talks about better sleep hygiene, as sleep is very important to someone who's experienced a brain injury and experiencing challenges related to a potential brain injury. Next slide. This is even smaller print, but I did want to make note that on the left is the provider guide on impulsivity, and on the right is the participant guide. And instead of saying impulsivity, we say ways to think before acting. The provider guide is written in language for the provider, whereas the participant guidebook and tips are written in language to the participant. Some of the strategies may be similar, but they are written specifically to the audience. Next slide. This slide shows a way, and I know this is very small as well, but it shows a way to use those strategies. If pick 2 or 3 strategies per challenge. You don't have to start going through all 9 strategies at one time, but pick 1 or 2, maybe 3. If it works, highlight it, circle it. If it doesn't work, cross a line through it. Each individual is going to be different. One strategy may apply to interrupting someone in a group setting and how to, mitigate that. If the individual is never in a group setting and it doesn't apply to them, or they don't feel like they have a challenge with being in a group setting and interrupting, they can mark a line through it, and they don't even have to worry with trying to utilize that strategy within their daily life. Next slide. So NASHA provides this tool. The state provides it to you for free use, but NASHA does have some additional support available, and we have this in the form of office hours. On this QR code, you can register for office hours, which happens the 3rd Wednesday of each month from 2:30 to 3:30 Eastern. Office hours are designed for you to come, ask a question, and go on. You don't have to stay for the full hour. You certainly can to hear what other questions people have. But this is designed for providers, screening partners, providers that would like to do screenings, providers that have questions about screenings, to come and ask their questions to the NASHA staff. I do want to say that this isn't a time to share personal data about a person that you are screening, but just ask screenings questions in general. Also, we have a screening partner app. Of those of you out there that are providers or part of organizations, we invite you to be a North Carolina screening partner. And we have an app available for you through this QR code. And I believe we're also going to be putting the link in the chat. This gives you a quick access to the OBIS resources and ways to get extra support. And you can download this web-based app on your desktop directly. So you have it available as a quick way to get to OBIS and the resources. Next slide. So the importance of screening, one of the things that I want to mention is Screening for the sake of screening isn't what we're asking. We're asking for screening in order to identify challenges that may be present that are causing service delivery barriers. We're also trying to understand what of those barriers need to be accommodated and how those accommodations can be implemented. We're also going to increase a person's ability to advocate for themselves as they can use these screening strategies with other professionals they work with, their support system, those that live in their home. Maybe they can take them to a probation officer or another caseworker to help advocate for their needs in whatever services they're receiving. Next slide. So I'll often get this question of, well, we've identified that someone has a brain injury. I must need to send them for a neuropsychological evaluation. And I know those are big words. Neuropsychological evaluations aren't always needed. Neuropsychological evaluations are very useful, and I have much respect for neuropsychologists and the work they do. However, neuropsychological evaluations can be very expensive. They can be very long. And even if you do find a neuropsychological evaluator, you may be on a long wait list. So what we advocate for is the first tier of screening would be self-report. And that's something we do with the OBIS. A person self-report their potential history of brain injury. If the tools and strategies that are incorporated aren't quite enough for the individual, we recommend a neuropsychological screening. And these can be done by, in most states, by a master's level clinician. We even have some information about how to be a neuropsychological screening evaluator and incorporate that into your practice on the NASHA website at nashia.org. If the neuropsychological screening results aren't fully helping an individual at that point, then the neuropsychological evaluation may be something that you need to consider. But not every organization can afford it or find it, or not every participant needs to sit through it if they can take a screener or self-report with supports does the trick. Next slide. I want to share some data that we've already received through OBIS. This is 2025 data. It shows the different settings that the OBIS is taken in. Just to show you, the first column there, the first blue column, is the criminal justice / correction setting. This chart shows us that out of 729 individuals that screened within the criminal justice corrections population, 71.3% of them screened positive for a potential brain injury. So that's actually a larger number than what our meta-analysis found earlier in our slides that showed 60.25% of those in the criminal legal system have experienced a traumatic brain injury. Next slide. This slide shows us of the individuals that have screened positive for potential brain injury, those that have experienced challenges related to potential brain injury. These are the symptoms that they are showing in the symptoms questionnaire. For example, the third bar down on inattention. Of those that screened positive for potential brain injury, 939 of those, or 71.9% of those individuals, showed that they have challenges with inattention. So this tells me, if I was a program director or a clinical director somewhere, that if I have 71.9% of the individuals that are screening positive for a brain injury are having difficulty with inattention, then that may need to be an area that I need to support my staff in additional training about how to work with someone with inattention needs. Next slide. All right, so there's some more information about the OBIS. Here's a link to access the OBIS. The subscriber name is North Carolina. It does have a space. And the password or subscriber code is 704. If you have any questions, please reach out to Scott Corney. If we've got that email address in the chat. He can connect you with more information about the OBIS or more resources. We also ask that when you take the OBIS, we want you to do a couple tests before you administer the OBIS with an individual. Because ethically, it's good to experience a assessment or an evaluation before you give it to someone else. You can also know what it's like going through the test questions, so you know what level of administration to give to an individual. When you go through a test record, we've got a flyer to show you how to go through a test record. But we do ask that the second time you enter the subscriber code 704, you add an extra 0. So 7040 is your test subscriber code. That way we know to throw that information out of our data set and to not include that in our official data that we provide. So we'll get you that flyer on how to perform a test record, and you can test the OBIS and be ready to administer it to participants. Next slide. All right, now I believe we have some time for Q&A. And we did have someone in the Q&A ask, how do I know if my child has had a brain injury in case they show no, or a brain tumor in case they show no symptoms? That would be something that would have to be imaged and diagnosed by a medical provider. That's not something that the OBIS will be able to diagnose, as it's not a diagnostic tool. If you get to the question about if you've ever had a brain tumor, that in the OBIS, that is, you would answer yes if you've been told by a medical professional that you've had a brain tumor. Not that you suspect you have one, but what if you've been told that you have one. All right, and Amanda has put how to create a test record into the chat so that you'll be fully prepared to do a test record and be prepared and ready to administer the OBIS to an individual. All right, and I'm sorry, I don't recall who will be moderating any further questions for us, but I'll be happy to look in the chat and the Q&A for any further questions that anyone might have.
Wonderful. Thank you, Haley. Are there any other questions or comments that anybody would like to put in the Q&A box before we conclude for today?
And Scott, I'll also be open to taking any concerns or comments that people may have about how, any barriers that they may foresee with implementing the OBIS in their organization. As like I said earlier, we have 20 subscribers and we've been going since 2023. And we've had much experience with helping providers work through some of those barriers. So we'll be happy to address any potential barriers that someone may be seeing as well.
Wonderful. Thank you for that. So at this time, I do want to thank you, Haley and Amanda, for the presentation today. There's a lot of great information that you all covered. I did want to point out a few things that, if you could please note that this is the first statewide initiative to include acquired brain injury screening as opposed to a sole focus on traumatic brain injury screening. So we're very excited to start identifying all acquired brain injuries, not just traumatic. And then the symptoms questionnaire specifically is a really welcomed component that we're able to offer through the OBIS platform that hadn't been available in the past. Because in the past there was a big concern when identifying a possible brain injury, but then not having any support to offer the individual. So the symptoms questionnaire really helps provide some of that more immediate support until they can get further connected to medical professionals to substantiate the brain injury and ultimately into hopefully services and supports within the community. If you could please spread the word about this platform through your networks, that would be wonderful. We really are hoping to be able to saturate the state with screening awareness and opportunities for anyone and everyone. Again, this isn't just for tailored plans, it's not just for providers, it's for everybody, right? Individuals, families, clinicians, and anybody else that is interested in taking the screening. The link and the QR code to the OBIS platform, along with the subscriber name and password code, are posted on our Division TBI webpage. So I encourage you all to take a look at that, as well as a recording of this session today will be available on that same webpage in the near future. The first presentation we had, that recording should be available now. And then if you could please be on the lookout for, we have several upcoming brain injury initiatives as part of our TBI State Action Plan. And that is also actually posted on the TBI webpage as well. So I really encourage you all to take advantage of reviewing that to see all of the upcoming goals, objectives, and milestones that we're going to be working on over the next 3 years. And really appreciate your involvement and support of the brain injury community. So thank you again for coming today, and I'm going to hand it off to Latoya to do a final wrap up. Thank you, everybody.
If we did not get the opportunity to answer your question during the webinar, questions and feedback are welcome at bhidd.helpcenter@dhhs.nc.gov. The recording and presentation slides for today's webinar will be posted to the TBI and DMH DDSUS webinars webpage. The links are included in the chat box. There will be a brief survey following today's webinar, and we would appreciate your time completing it. This concludes our webinar for today. Thank you for attending.